Kia ora everyone, just setting up. Have my toast. All right, mōrena. Ata mairi e kia tātou katoa. Koutou e whakarongo ana ki au e pānui ana tēnei pukapuka, ngā mihi kia koutou katoa. Kia koutou e whai ake I enei o kōrero I roto I te pukapuka, ngā mihi kia koutou. You know, feel free to have a look at this book online and purchase it. It might be worthwhile. I saw that it was on Kindle as well for cheap. So Dr. Joanna Moncrief is a psychiatrist and a critical psychiatrist, and she wants to get the messages about psychiatric drugs, how they work and how to come off them. So my name is Dr. Diana Kopua. I am a psychiatrist, a fellow with the Royal Australia New Zealand College of Psychiatry. I'm also a psychiatrist with the Hauraki PHO, and I provide advice for GPs. I can tell you that some of the requests do not reflect any transformation. It really is quite biomedical in the way that our systems operate, and so I thought that I would share some lessons here as opposed to going to keynote addresses and doing trainings with disciplines inside their institutions or organizations. This way, mōrena erana, Joyce. Oh, nice. I'm glad you're tuning in. Now I've forgotten what I was going to say, but it was good, I tell you. Right, key messages. I really want us to get the key messages without having to go back to all the readings. We're up to number 11 here. But many people think that mental health problems, emotional problems, are an illness. The problem with seeing them as an illness is that then we leave the responsibility for what to do about our emotional problems to someone else outside of ourselves, to experts, and those experts are doctors, and the doctors who specialise in emotional problems are psychiatrists. And mental health problems are everyone's problem, and what we do about it is up to us, and our ordinary people taking control of what's become too out of hand is absolutely necessary. And that's not just for the PSY disciplines of psychiatrists and psychologists, but for employers and parents and everyday people thinking about how to be different. We need to get better at getting better. And so Dr. Joanna Moncrief provides an honest evaluation of mental health problems. She has taken us through her alternative to a model, to a disease-centered model when looking at drug taking, to a drug-centered model. And the disease-centered model focused on the medication like Panadol and aspirin, helping with some underlying processes that were due to biomedical or biological reasons. And although the Panadol and aspirin do not reverse the disease process, they can help with the symptoms of the disease process. Opiates, who can help with pain relief, can also act on the biological processes, but they also brain or mind altering substances, and that's what psychoactive, psychotropic medication is, a mind-altering substance. And it does not imply that it is acting on any disease process, because in fact psychiatric problems do not have a disease process known. What we do have is many theories, particularly to do with neurotransmitters, which are chemicals in the brain, and in many other parts in the body as well, they operate on, which is why we get lots of adverse reactions. So yesterday we talked about the spell-binding effects of psychiatric drugs and the idea that you can be spellbound. And I'm just going to carry on now. The next section is the effects of long-term use. I'll just sip on my coffee and check in to see if you have any partai. Kia ora. Morning, everyone. Right, hopefully we'll be able to learn some more stuff today. Okay, so long-term effects. Now you have to know that, and hopefully Joanna will talk about it, but many of us in psychiatry have been taught that when we work with people who have been given this diagnosis of schizophrenia, that people must stay on that medication long term. There has already been reference to evidence from research where a 7-year study was completed, and for people who had a first episode of psychosis, and they did better, those who were taken off their drugs in a very planned way and followed up over 7 years, did better than those who remained on the medication. And again, just a little bit of a disclaimer: this is not for me. This is not me here saying if you're on these medications that you must come off them right now. It is to inform you, because if we ordinary people are responsible for thinking about mental health and emotional problems differently, it is the language that gets in the way. And it's also the fact that many of the publications that have been shared in the past have not wanted to share anything that's against a message that has any political clout or supports other industries that are capitalizing on everyone believing that there is a chemical imbalance. Better start reading. When a drug is taken repeatedly, the body changes to try to neutralize the drug's effects. This is why drug addicts need to keep taking higher and higher doses of drugs like heroin to get the same buzz. This phenomenon is called the pharmacological tolerance. The body does this in various ways. In response to a drug that affects the activity of the brain's neurotransmitters, the body may adjust the number of receptors for that chemical, or it may increase or reduce the sensitivity of the receptors. And I think I said a couple of readings ago that these chemicals are released from the nerve, and the medication acts on either blocking the receptor site so that the chemicals can't be recycled. And if we do that, that means we leave more chemicals in the space in between the nerve cells, right? Inside the space, nerve cell, and there's a space. More chemicals in here will mean that there will be a change, a physiological change. So we will develop more keyholes, receptor sites, so that these chemicals can attach to. And that's what happens when we take this medication. These changes can be viewed as the body's adaptations to the presence of a drug. Animal studies show that the body starts to adapt within days of starting a drug that is taken repeatedly. The consequences of this process are that the acute effects of drugs diminish and larger doses are required to obtain the same effect. If the drug is stopped, then the body's adaptations are suddenly unopposed by the presence of the drug, and they give rise to withdrawal symptoms. These will persist until the body has returned to normal. However, there is scant research into the sort of bodily adaptations that occur in response to different types of drugs. We also have few data about how long it takes the body to recover its previous structure and function after a drug is stopped, and whether drug-induced changes are reversible or not. It used to be assumed, for example, that once a drug is stopped, the body quickly returns to its previous state. Withdrawal symptoms were thought to last for a few days or maybe a week or two at the most, and then resolve. Experience with benzodiazepines and antidepressants suggests this is not true, however. Withdrawal symptoms can persist for months or even years after the drugs are stopped, which suggests that the body takes much longer to recover from the effects of repeated exposure to drugs than was previously thought, at least when some drugs are concerned. And she's going to talk about that more in chapter 9. I think this is really important when you aren't feeling yourself and you go to your doctors, and we've already talked about promoting the idea that people can't recognise things like depression as though depression is a disease process. And so while you're talking about something else, we had a colleague that did that and that had that experience in Australia just recently. And so you go to the GP and they're listening to you because they're trying to figure out what might be going on. And of course, if they are worried about this so-called term depression, they are very quick to prescribe medication. All you GPs out there, particularly you Māori GPs, I really hope that you are avoiding quickly running to the script for people who are having emotional problems. And if there's a reason for this to sort of slow down, it is for this reason, because of the impact of withdrawal that has not been hugely investigated, even though many patients have gone into a psychiatrist, into a doctor's room and said how they feel after coming off medication. In fact, in psychiatry, both in my nursing and psychiatry career, I have been taught that when people come off, we have to be careful because they can relapse, and that's why we like to keep people on medication. But in fact, is it that they're relapsing, or is it that there is withdrawal? Because withdrawal symptoms or experiences can be significant, and it can fool even ourselves who are withdrawing to believe that we might be becoming unwell again, and it can be freaky, and you think you need to be on the medication again. So coming off these medications can be really challenging. Another issue is that the adaptations the body makes to try and... Oh, hang on. Am I at the right place? Yes. Another issue is that the adaptations the body makes to try and counteract the effects of drugs are unpredictable. So what is our body doing? We don't know. So coming off the medication, we don't even know what has happened to the body. So taking the drug away straight away fast can leave the body a little bit freaked out. In some cases, the body's changes may overshoot and produce effects that are the opposite of what would be expected from the effects of taking the drug. Did you get that? The disorder called tardive dyskinesia, for example, is caused by prolonged use of drugs that reduce dopamine activity. Dopamine is one of those neurotransmitters, including any antipsychotics. Yet the symptoms reflect overactivity of the dopamine system. Therefore, it appears that when someone develops tardive dyskinesia, the body's adaptations to the presence of dopamine blocking drugs are too efficient. The presence of dopamine blocking drugs are too efficient, and the person ends up showing signs of excess dopamine activity. The mechanism of tardive dyskinesia is probably more complex than this and has not been worked out completely, but it illustrates how the body's response to drugs may be maladaptive. Since tardive dyskinesia can persist after antipsychotics are stopped, it also demonstrates how the changes induced by drugs can have long-lasting or even permanent effects. A similar phenomenon may occur during long-term use of opiate painkillers. Although in the short term opiates are anesthetic drugs or agents that reduce pain, when they are used continuously for long periods, they may conversely increase the body's sensitivity to pain. And I do remember being in a lecture with the pain management team who talked about that and said that in their clinic they were actually reducing the doses of pain relief that people were on because long-term use of these painkillers, opiates as painkillers, was actually increasing your sensitivity to pain. Not sure how many of you knew that, but there's another point that I think is important. Again, the mechanism for this is likely to be that the body has overcompensated for the pain-reducing actions of the drugs, possibly through suppressing its natural pain-killing hormones, the endorphins. Please, if you're on painkillers, don't make any rash decisions by yourself. Do it in conjunction, in partnership with the doctor who's prescribing for you. Drugs can also cause direct damage to the body and brain. An example of this may be the reduction of brain matter that has been found to occur following long-term use of antipsychotics. And there is evidence in this that Joanna will talk about in Chapter 4. Some researchers propose that tardive dyskinesia is also a result of antipsychotics causing direct damage to nerve cells in certain areas of the brain. In most cases, we do not know the exact mechanisms underlying the harmful effects of drugs. What we do know, however, is that occasionally psychiatric drugs give rise to symptoms that suggest serious and sometimes lasting damage to parts of the brain or body. Other examples include prolonged neurological and psychological symptoms following benzodiazepine withdrawal and persistent sexual dysfunction following discontinuation of SSRIs, which she'll talk about in Chapter 5. What do you reckon? I'm hoping that it's making sense. Before the 1950s, the drugs used in the old mental hospitals and those prescribed by GPs to people who were anxious or depressed were regarded as acting in a drug-centered way. At that time, most of the drugs used in hospitals were sedatives, and they were regarded as acting basically as chemical restraints. When drugs such as chlorpromazine, which is Largactil, and thorazine, which we now refer to as antipsychotics, were introduced in the 50s, they were thought of as special sorts of sedatives. They were noted to produce a different quality of sedation from the run-of-the-mill sedatives of the time, mainly the barbiturates and the barbiturate-like drugs. But they were considered to be sedatives nonetheless. It was even suggested that antipsychotics worked by inducing a neurological disease or syndrome with similarities to Parkinson's disease, and that the symptoms of Parkinson's disease-like state supplanted the symptoms of the underlying psychiatric disorder. Gradually, however, over the course of the 60s, the new drugs came to be seen as disease-targeting treatments that acted in a disease-centered manner. The area that they were drugs that the idea that they were drugs that produced profound and unusual altered mental states, although briefly the subject of much interest, was swiftly forgotten. Psychiatry adopted the disease-centered model of drug action because it bolstered the idea that psychiatric disorders are the same as other medical conditions and can be managed and treated in the same sort of way. It was never properly tested, however. It was never compared with the alternative drug-centered explanation of how drugs work, Instead, the disease-centred model simply came to be assumed to be the case. People stopped being aware that the effects of drugs could be understood in another way. Along with this change in thinking about how drugs work, the undeniable fact that psychiatric drugs have psychoactive properties was simply no longer mentioned. What do you reckon? So even when these drugs, these earlier sedatives came about that were different from the ones that we're used to, they were known even then as sedatives, and over time they have moved into an idea that they are targeting an underlying disease process, and that's probably the biggest lie that we've all been caught in the web of, which is this idea that there's this chemical imbalance and that we must take this medication to balance those chemicals. And what we're saying here is that actually all drugs are foreign and they act in a certain way, and the body has to adapt, and sometimes the body's adaptation is maladaptive and contributes to long-lasting and sometimes irreversible effects on the body. So I might just keep going. Shall I? Yeah. We have seen that there is no convincing evidence that there are specific biochemical abnormalities underlying mental disorders that could explain the action on drug treatment in a disease-centred fashion. Even if such abnormalities existed, we would still need to discount the impact of the mental alterations the drugs produce in order to suppose the disease-centred model. We have seen that, other evidence that might support the disease-centred model of drug action is also lacking. Placebo-controlled trials where the effects of taking an active drug are compared with the effects of taking a dummy tablet form the main justification for the use of psychiatric drugs. So that's researched for the drugs to come onto the market. They have to be compared with a placebo pill. Excuse me. But these do not distinguish between whether a drug acts in a disease-centred or drug-centred manner. Placebos are usually made of pharmacologically inert substances, such as chalk, that have no effect on the body. A drug that produces any sort of noticeable effects, and especially one that has psychoactive properties and changes aspects of mental activity and behaviour, will inevitably impact differently on the symptoms of mental disorders. Therefore, results of placebo-controlled trials do not support the disease-centred model of drug action. True. So if you're passing a drug to see, particularly based on whether it reduces symptoms, well, these drugs we're talking about are mind-altering, so they impact the way we think, feel and behave, and sometimes disconnect us from having an emotional response. And so that might be perceived as reducing your symptoms and therefore impacting the disease process. Does that make sense? Comparative studies. Evidence that might support the disease-centred model includes comparative studies showing that drugs that are believed to have specific disease-targeting effects in certain conditions are better than drugs that are not thought to have such effects. Properly conducted comparative studies are few and far between, however. I will describe some of this research in more detail in the rest of the book. To summarise briefly, in studies of people with depression, numerous drugs not conventionally regarded as antidepressants have been shown to have similar effects to antidepressants. Moreover, antidepressants themselves come from many different chemical classes and have a diverse range of chemical effects, so it's difficult to see how they can all be acting on the same biological condition. Drugs referred to as mood stabilizers, including lithium, have not been shown to be superior to other sorts of sedatives in people diagnosed with manic depression or bipolar disorder. Several studies of people with psychosis or schizophrenia show that some other sedatives have similar effects to antipsychotics in the short term. Animal research, animal models of mental disorders such as depression and psychosis are used with the aim of demonstrating that drugs have effects on particular disease mechanisms. Yet this research does not, in fact, identify drugs with specific effects in specific disorders. First of all, the models are so imperfect it is doubtful that they really have any relation to the human conditions they are supposed to replicate. This is acknowledged even by leading psychopharmacology researchers. Over and above this objection, research using animal models frequently fails to discriminate between drugs that are thought to have specific effects and those that are not. In all animal models of depression, for example, positive results have been obtained with numerous drugs that are not thought to have antidepressant activity in humans, including amphetamines, antihistamines, antipsychotics, atropine, opiates, phenobarbital, zinc, and antibiotics. In contrast, selective serotonin reuptake inhibitors, those SSRI antidepressants, typically do not produce positive results in commonly used animal models of depression. One of the most commonly used animal models of schizophrenia or psychosis is called the stimulant-induced stereotypy model. This involves administering amphetamines or other stimulant drugs to animals, usually rats, to induce abnormal movements called stereotypies. These movements are thought to be induced by excessive dopamine activity, and they are effectively reduced by dopamine-blocking drugs such as antipsychotics. Therefore, this test is a test of the inhibition of dopamine activity rather than a test of antipsychotic action. It identifies antipsychotics that have strong dopamine-blocking effects, such as haloperidol, but does not detect antipsychotics that lack this effect, such as clozapine and some other second-generation antipsychotics. If the disease-centered model cannot be definitively supported, the drug-centered model of drug action has to be accepted as the default position. No one disputes that psychiatric drugs alter normal mental functions, even if these psychoactive effects have attracted little attention in the last few decades. But it would be implausible to think these effects have no impact on thoughts and behaviours that constitute the criteria for mental disorders. Indeed, as I will show in subsequent chapters, research on the effects of psychiatric drugs is entirely consistent with a drug-centered explanation of their effects. Implications for treatment, the last little section for chapter 2. Whether you adopt the disease or drug-centered model of drug action makes a difference to how you view the usefulness and potential dangers of drug treatment. Because the disease-centered model suggests that drugs are correcting an underlying disease or abnormality, it tends to favour the use of drugs and encourages us to understate their dangers. The disease-centered model tells a heroic and optimistic story about modern technology combating a biological enemy. What's not to like? The adverse effects the drugs induce, although not completely denied, get overlooked in all the enthusiasm. The trouble is that the story is just not justified. There is no convincing evidence that any type of psychiatric drug works in a disease-centered way. The drug-centered model tells a different and more worrying story. It emphasizes that drugs are foreign substances that change the normal functioning of the behavior. It highlights that we don't even know all the ways in which drugs changing it, and what the short and long-term consequences of these drugs are. The drug-centered model urges us to presume that drugs will be harmful, even though we may decide on some occasions that, on balance, the risks involved are worth taking. Adopting a drug-centered approach enables us to have a comprehensive and realistic view of what drugs can and cannot achieve in the arena of mental health. That was a cool way of finishing chapter 2. I note that the majority of chapter 2 is about adopting a model to understand how drugs act. And one is the disease-centered model, implying that when you take medications that psychiatrists or GPs prescribing psychiatric drugs give you, when you take them, that using a disease-centered model, then taking that drug is to help you impact the disease process. But in fact, it's not necessarily changing that at all. Instead, the alternative model is the drug, what do you call it? The drug-centered model. And the drug-centered model implies that we're taking this drug because it's altering our mind, the mind-altering substances, and that can impact the way we think and feel and behave, and that can be helpful for people who are in significant distress. But using this model also says these drugs are not managing any disease process, and they come with some significant adverse reactions that we need to be aware of before we even engage in prescribing. Now that is the ABCs of medicine, and that is something that we're taught, that we have to talk to the adverse effects, and doctors can only do that if the publications of, if we are researching some of these problems, including withdrawal. And as we said earlier, some of those things aren't included in the publications, and what trainees aren't and are given is determined by the philosophy of and the ideology that is promoted by their teachers or their school. And our college is, their curriculum, we believe, is racist, and the psychology curriculum is racist, and so it makes sense that these things aren't really, we aren't informed of these wonderful gems in Joanna's book, and yet we make up a big population of people that are given these medications that have these long-term effects. And given that there is research, which I was never shown, even though the research happened during my training, that showed that medication and taking it off had better long-term effects for your quality of life, and compared with those who stayed on it long-term. And that doesn't sit well with me. I hope you have a great weekend. I'm not sure if you have any questions. I'll just sit here for a bit. There's a bit of a lag between the messages and me talking. So if there's anyone that has any questions or comments, feel free to put them up and I'll try and respond. Otherwise, have a great day. Bye. Take care, everyone.